Welcome everyone. Today in our series of urology exit exam preparation, we are discussing the scenarios in Uro-Technology. Thank you for the trainee who has given the consent to record this session, which will be a good revision tool. So we are not going to have a timed one, Piyush, because as you know, the technology table always contains small bits of multiple possible scenarios.
Yeah.
So there is no need for time. We'll just play around 40 to 45 minutes and then see how it goes on. Okay,
Okay.
good. You have a patient presented for ureteroscopy and laser lithotripsy. He has 8 millimeter left upper ureteric obstructed stone. You are in the theater. So what kind of urotechnological equipments you may keep ready for this patient?
So for this patient, in terms of the equipment I will use, it'll be a size 22 French rigid cystoscope with a 6 French open-ended ureteric access catheter, GUIDEWIRES. So my first choice speed sensor guide wire. On standby would be a Thruma guide wire. In terms of equipment to deal with the stone, I would have a semi-rigid ureteroscope. Other equipment on standby would include a flexible ureteroscope and also a ureteric access sheath, along with the laser machine and a laser fiber. Further technology would include a C-arm.
Okay. How does the ureteroscopy works?
There are two types of ureteroscopes. There are semi-rigid and flexible ureteroscopes, but they can also be classified according to the means of light transmission. So a rigid ureteroscope works via the use of fiber optics contained within a metal case, as does a flexible ureteroscope. But there are also flexible scopes which have digital transmission of images via digital transfer.
What is the size of the semi-rigid ureteroscopes you commonly use?
So the size of the semi-rigid ureteroscope has two numbers assigned to it. The first number is the size of the distal tip, and the second number is the size of the scope going more proximally. In my practice, I commonly use semi-rigid ureteroscopes, which are 4.5 and 6.5 French, or 6.5 and 7.5 French.
Okay. So what are the components of a semi-rigid ureteroscope?
A semi-rigid ureteroscope consists of an eyepiece and a block to which the light lead is also attached. It consists of a working channel which is approximately 34 centimeters long and has a diameter of 3.4 French. It can also have two working channels, depending on the type of scope, and it also has two ports for irrigation. Within the metal casing of the scope contain the fiber optic bundles running parallel to the working channel.
Do you know what was the materials used before the fiber optic materials were introduced?
It's most likely that the materials used were the Hopkins rod-end system, consisting of long glass rods separated by short air spaces.
So what is the advantage or disadvantage of them?
The main advantage is that the Hopkins rod-end system allows for greater transmission of light and an image quality. It allows for magnification, and it also, because it was of a smaller diameter, allows for the accommodation of a parallel access sheath. With fiber optics, this allows for more flexibility with the scope instead of the rigidity. So those are the main advantages of the fiber optic system.
Okay. How does the flexible ureteroscope works?
A flexible ureteroscope's components, it is 70 to 80 centimeters long. It works on the principle of, so if you look at a fiber optic flexible scope, it works on the principle of fiber optics. The fiber optic bundles are non-coherent in terms of within the light lead, so they don't have the same arrangement either in the light lead, but they have to be coherent to the same arrangement at the distal and the proximal end in order to produce the same image that's received. A flexible ureteroscope has an eyepiece, it's got a light post, and it also has a lever which allows for deflection of the distal tip, and this can be deflection to a degree of up to so on either side of up to 150 degrees. In terms of the digital flexible ureteroscopes, they do not use fiber optic bundles for image transmission. They instead work on the principle of a photon striking a charge couple device, which is found at the tip of the scope, and this provides a superior image quality. Furthermore, flexible scopes have one working channel, and this is normally 3.6 French.
Okay, so you can label that the image will be a coherent bundle while the light is a non-coherent bundle, just as same as the SEMIRIGID ureteroscopes. Apart from the charged coupled device, which is CCD chip in digital flexible ureteroscopes, the other option is CMOS chip. CMOS stands for complementary metal oxide semiconductor. When I post this in the YouTube, I will add all those things in the background video. What is the disadvantage of digital flexible ureteroscopes?
The main disadvantages of these are that they are more expensive. Because they're disposable and single use, there may be concerns about the environment. The tip of these scopes is also usually 9.8 French. Therefore, it can be difficult to cannulate the ureteric orifice with it.
And they are also expensive. And the digital ureteroscopes could be reusable or disposable. Both are available. All disposable or in general digital scopes. You can generalize it.
Yep.
Okay, you explained some guide wires. Could you further explain what is the made of sensor guide wire?
So a sensor guide wire, for the majority of its length, has an inner stainless steel core, which is coated by polytetrafluoroethylene or PTFE. However, the tip of the wire is flexible and hydrophilic, this instead consists of a nitinol stainless steel core, which is coated by hydrophilic copolymer, and this contains tungsten to allow with fluoroscopic vision.
Any differences in the tip design?
So I mentioned that the inner core is made of nitinol, and the tip is coated with a hydrophilic copolymer, and it contains tungsten and polyurethane.
Okay, you can also say the tip design could be like a straight tip or angled tip or J tip. Depends upon the tortuosity of the ureters. So you are going to treat this upper ureteric 8 millimeter stone. So what is your approach? Just technologically, how will you going to use the equipments?
So I'll first use a 22 French cystoscope to perform assisted ureteroscopy to enter the bladder. When I identify the ureteric orifice, I'll cannulate it with a 6 French open ended ureteric access catheter. I will perform a retrograde pyelogram to classify the pelvic ileal system, and then I will insert a sensor guide wire up to the level of the renal pelvis and confirm the position and a classification using the image intensifier. I'll then insert a 6.5 to 7.5 French semi-rigid ureteroscope up the ureter alongside the sensor wire to dilate it. And if I'm having difficulty, then I will use a second sensor guide wire to insert the scope If I reach the stone of the scope, then I will fragment it using a holmium YAG laser fiber. And then if the procedure is successful, but I need to place a stent, then I'll do so. I commonly use in my practice a size 6 French and 24 or 26 centimeter ureteric stent.
Okay, say for example, when you are using the semi-rigid ureteroscope and the stone migrates to pelvis, you are able to reach the pelvis with semi-rigid ureteroscope, but the stone is in a wrong angle. How can you treat the stone further?
So the stone could be treated further by use of a flexible ureterooscope. This can be inserted into the renal pelvis either over a safety guide wire, which is left throughout the procedure, or through insertion via a ureteric access sheath.
What is ureteral access sheath?
This is a device that facilitates repeated passage of instruments to and from the renal pelvis, and it also reduces the intrarenal pressures during surgery. It can be between 13 to 55 centimeters long, but the commonly used lengths are 36 and 44 centimeters. It consists of an inner trocar and an outer sheath. The inner trocar has a diameter of between 9.5 to 13 French, and is the element through which which is inserted over the guide wire. The outer sheath has a diameter of between 12 to 16 French. It has a hydrophilic coating, and the inner lumen consists of PTFE.
So what are the advantages and disadvantages of access sheath?
So the advantages of an access sheath are facilitation of passage of instruments to and from the kidney during surgery, in order to reduce the risk of ureteric trauma and stricture formation, and also reduction of the intrarenal pressures during surgery. The disadvantages, however, are that it's more difficult and risky to insert in a ureter that's not been operated on before. It can also cause ureteric trauma, and even on removal, it can then cause ureteric avulsion. So it needs to be removed very carefully under direct endoscopic vision.
Prolonged placement can cause mucosal ischemia because of the shear pressure from the access sheath. Okay, you are using a flexible ureteroscope and holmium laser to fragment the stones. What are all the types of holmium laser settings you are aware of?
So the settings on holmium laser equate to the energy and the frequency, and also the pulse width. So, for example, this will depend upon the level of fragmentation that's desired. So, for a stone fragmentation, then one would select a high energy, low frequency and short pulse width. Whereas if stone dusting were desired, then this would involve a low energy, a high frequency, and a long pulse width. So an example of the latter would be putting the energy on 1 joules, putting the frequency onto 10 hertz, and then a long pulse width.
Okay. The primary difference is mainly the energy. If you use high energy, it will produce fragments, big particles. If you use low energy, it will just touch and break only a low area of the stone, so that results in dusting. So predominantly the energy decides fragmentation and dusting, while frequency only increases the same process. Even with fragmenting high energy, if vision is clear, you can still increase the frequency, which will speed up your fragmentation. And in dusting, commonly we use high frequency because we are having low energy. We have a 30 watt laser or even a 120 watt laser. So why can't we use the full efficiency of the laser by increasing it as a frequency? That's why we have using high frequency. So predominantly fragmentation and dusting depends upon the energy. The frequency only speeds up the process. Long pulse width is a good efficient one, so that the pulse width is longer, so it gives enough time for the laser to work on before the next laser energy is striking the stone. That's why the long pulse width is better, especially for dusting. Good. Stone is nicely dusted, and there is some particles you are able to remove with the help of the basket, and then few very small particles you left it for, say, spontaneous passage. So how will you exit from this surgery?
I'll ensure that there is a safety guide wire in place, which should have been present throughout the surgery. I will then remove the ureteric. I'll then remove the ureteric access sheath and the flexible ureteroscope under direct vision. I'll then determine if I need to leave a stent in situ, and if I do, then I will insert it through reinsertion of a rigid cystoscope and insert the stent over the guide wire. If it's to be left in temporarily, then I will leave a stent with nylon string on place so the patient can come back and have it removed by a urology CNS. And I'll also decide whether or not I need to leave a catheter. If the procedure are uncomplicated, then I would not leave the catheter and empty the bladder through the rigid cystoscope sheath.
What are the material stents made of?
Stents are very commonly made out of copolymer, with Percuflex being the commonest. They can be made from polyurethane. Another material includes silicone, and there are also metallic stents which are more commonly used for management of ureteric strictures.
Okay, what metallic stents you aware of for strictures?
Sorry, can you repeat the question? It just broke up.
Yeah, what metallic stents you aware of for ureteric strictures?
So there are two main types of metallic stents, which are resonance and Memicath.
Okay. Now we turn to a different scenario. You have a 3 centimeter stag-on calculus for which the patient is listed for PCNL. For PCNL, what kind of Uro-Technology equipments you need?
So for PCNL, I'll again need the C-arm. I'll require a PCNL set, and I'll be thinking about a puncture. So I'll require dilators, a nephroscope, and a lithoclast.
Okay. What about the access? Any specific things you need for access?
So for the access, it would be guide wires, contrast, an access needle, an ultrasound scanner, and also dilators, which could include balloon dilators, Aplatz or Olkins dilators.
Do you know how these access needles are made? What are the properties?
So the access needle needs to consist of a stylet, and the needle, it needs to be a hollow bore needle, but I can't recall the other properties.
Okay, it could be like a 3-part needle or a 2-part needle, and the tips may be like a beveled tip or a diamond tip. Beveled tip will help the guide wire to come out on one side of the needle so that we can use the bevel tip to see that the guide wire is coming on the side where there is no stone, or we can make the guide wire to enter the PUJ. We can rotate the bevel tip. Diamond tip means the guide wire will come exactly in the tip, but diamond tip is good if there is a small calyx and difficult to access like calyceal diverticulum. And the needles may be like 18 gauge, and the length may be like 20 centimeter, and the 2-part needles may be like 18 or 20 or 21 gauge. How will you dilate a PCNL tract? The guide wire is now placed adequately.
So I'll use the method of balloon dilatation. Over the tract, I will over the guide wire. So I'll ensure the guide wires are crossing the PUJ. I'll use one as the working wire. I will insert the balloon over the guide wire, going just beyond the skin, and I'll then attach it to a manorbiter. I'll increase the pressure to 15 to 20 atmospheres, dilating under fluoroscopic vision. And then once the tract has been created, then I will backload the amplat sheath over the balloon.
Before you dilate the balloon, use the balloon, make sure that the amplax is already backloaded and ready, so that once it is opened, you can just insert the amplax sheath over the balloon. As you said, visualizing the shouldering in real-time fluoroscopy will prevent unnecessary injuries. Explain the nephroscope, how it is made.
So a nephroscope consists of the eyepiece. There is a light post, the light lead consists of a handle, but then in terms of the working elements, this has got a semicircular configuration, which is open on the superior aspect, and this allows it to be accommodated within the amplat sheath. In terms of the length of the scope, it's approximate, in terms of the length of the working element, this is approximately 15 to 20 centimeters, and light transmission works on the basis of fiber optics.
Okay. Do you know what is the size of the nephroscope commonly used?
I'm sorry, I can't recall.
Okay, it could be like 24 or 26 French. Do you aware of any miniaturized PCNL?
So there are smaller versions of PCNL that exist, with the rationale being that it minimizes complications such as blood loss. There is mini PCNL with the tract size of between 14 to 20 French. Ultra mini PCNL, the tract size is 11 to 13 French. And then there is micro PCNL, which is between 4.5 to 6.5 French.
So what is the advantage of micro PCNL?
A micro PCNL, it's because the tract size is smaller, there is a lesser blood loss, lesser risk of bleeding and blood transfusion, also of sepsis, and it can also be used it could also be used, for example, to access smaller stones which may not be amenable to ESWL or ureteroscopy, but where a standard PCNL tract size may be thought to be more excessive.
Okay, the micro PCNL has got a 3-part all-seeing needle. So we are just puncturing it. The outer sheath is 4.85 French. After removing the needle, you can use a flexible fiber optic telescope to dust the stone. That's it. You can't remove the stone. The stone is completely dusted, and it has to be passed out by the patient by drinking good amount of water. What are all the ways by which you can handle a bladder stone? What equipments you need?
So for a bladder stone, this can be handled, for example, using a rigid cystoscope or a cystoscope, and the stone can be removed intact as a whole through the sheath. So this is a system known as cystolithoepoxy. There's cystolithotrity, which is mechanical crushing of the stone, and this will be using a Maurmyers stone punch. There is also laser lithotripsy of the stone, or lithotripsy, so using an energy source. This can be done using a laser fiber, using a lithoclast, or using electrohydraulic or ultrasonic lithotripsy. And there is also a cystolithotomy, which is open removal, and this would require instruments from a laparotomy set in terms of basic surgical instruments.
Okay, you said Maurmyers stone punch. So how it is made of?
So this consists of this is a 25 French scope, which has a 0-degree telescope. It works through the inclusion of a sheath and the stone crunch itself. It allows for crushing the stone between the jaw of the grasper and the sheath. and it also consists of a eyepiece and light lead, with the transmission of light using the Hopkins rod lens system.
Okay. The main thing is it's a bit costly. It's a very sturdy equipment. As I said, 0 degree telescope. We need to make sure the bladder is full and the stone is crushed under visualization. There is a high chance of bladder mucosal injury if appropriate care is not taken. And what other methods by which we can remove the stones apart from periurethral?
So there is also percutaneous removal through the creation of suprapubic tract, and there is removal transabdominally. Traditionally, this via the open method, but the EU guidelines do also describe the use of laparoscopic or robotic assisted methods too.
Okay. How this?
And sorry, there's also extracorporeal shockwave lithotripsy.
Yeah. How this lithoclast works?
The lithoclast uses the production of ultrasonic energy at a frequency of more than 20,000 hertz. This is created through the application of electrical currents to piezoelectric crystals in the handpiece, and these expand and contract and produce high frequency sound waves, which are ultrasound waves. So this is at more than 20,000 20 kilohertz. These are then transmitted down the probe and applied to the stone, which is fragmented in a drilling motion. However, the probe has a hollow lumen through which suction of further stone fragments can then be carried out to remove them.
Okay, we'll go for the last scenario for the day. You have a 9 millimeter right kidney lower pole stone patient listed for ESWL. Anatomy is quite suitable for ESWL. How will you decide a patient pelvic axial anatomy suitability for ESWL?
There are three characteristics, and the favorable characteristics would be an infundibular pelvic angle of greater than 70 degrees, the infundibular width of more than 5 millimeters, and the infundibular length of less than 3 centimeters.
Good. So how this ESWL works? What are all the types of energy sources?
There are three types of lithotripsy which have been described: electrohydraulic, piezoelectric, and electromagnetic. The electrohydraulic lithotripsy works through the presence of two electrodes underwater, which have polar opposite voltages. Electrical current is applied to them, producing an underwater spark plug. This vaporizes the water and produces gas bubbles, which then expand and collapse, releasing a shock wave. And the shock wave is then focused onto the stone by means of an acoustic reflector. The piezoelectric lithotripsy works through the semispherical arrangements of piezoelectric crystals. These have an electrical current applied to them. They expand and contract, producing ultrasound waves, and their semispherical arrangement then helps to focus the stone onto the target. And then finally, there's the electromagnetic lithotripsy, which is the most commonly used in everyday practice. In this, the electrical current is applied to a cylinder, producing cylindrical waves. These are then reflected by a parabolic reflector to produce spherical waves. These are passed through an acoustic lens, which is the mechanism by which the stone is then focused on, the shockwave is then focused onto this target of the stone.
Okay. So what are all the techniques by which you can improve the efficiency of the ESWL?
So efficiency would be improved first of all by ensuring the correct patient and stone is selected and taking into account the skin to stone distance and the household unit density of ideally less than 800 units, a skin to stone distance of less than 11 centimeters, and also the skin to stone composition. Those which are more resistant to ESWL include cysteine, calcium oxalate monohydrate, and calcium phosphate. In terms of the procedure itself, one would need to ensure that the patient is adequately allergies pre-procedure, that I use a water-based lubricant as a coupling medium applied by hand. I'll start off with a frequency of 1 hertz. And in terms of the shocks per minute, I would ensure that this is at a rate of 60 shocks per minute. I'll use a ramping protocol and continuously image throughout the study. And I'll stop when satisfactory fragmentation of the stone has been achieved. Furthermore, I would not pre-stent the patient because this would absorb the shock waves. And post-procedure, I prescribe the patient tamsulosin to aid with clearance of the stone fragments.
Why tamsulosin is prescribed? What is the evidence behind it?
So the evidence behind tamsulosin, I can't recall the exact paper, but it has been shown to increase the clearance of the stone fragments from 75 to 91%, and it also reduces the time to the clearance of the stone fragments, episodes of renal colic, and reduces hospitalization time.
Yeah, but you need to mention that it is used off license in this indication. Okay?
Okay.
Good. You may be asked to draw the pressure wave, the pulse pressure wave. In this zoom we can't do, so it starts at 0 and there is a steep positive pressure font up to 40 megapascals followed by a negative pressure at 10 megapascals. The whole wave is like 4 microseconds. I think you can easily manage that. What is meant by F1 and F2?
F1 refers to the initial sharp peak in positive pressure, and this is due to the effects of acoustic impedance and spallation. So when the shock wave hits a stone, it creates acoustic impedance because its transmission through the medium is resisted. And this produces a compressive stress which overcomes the tensile strength of the stone and creates microfractures. And F2 then refers to the process of cavitation. So when the shock wave passes through the fluid, there are plasma bubbles which expand and collapse, releasing microjets of energy which are then directed against the stone surface and cause fragmentation.
Okay. In general, F1 is the source of the energy, F2 is the stone, and there will be a medium which focuses the F1 waves to F2. That's overall explanation. Nice to know. So what are all the imaging systems you may require during ESWL?
So the commonly used imaging systems are fluoroscopy, or ultrasound, or there can be a combination of both on the lithotripsers.
Good. I'm happy to complete this session now. Do you have any questions in this stone technology before we complete?
No, I think it's just probably more a question about exam technique because I think I've answered the question more directly. So, for example, you've asked about the components of the stone punch, and of the Maurmyers stone punch, but then I was waiting for you to say what are the advantages and disadvantages, but then that's something you mentioned. So if I get asked a question like that, so talk me through this, or what are the components? Is it just best to mention the pros and cons straight off as well without having to be asked?
Yeah, I will hold on the answers to the question. For example, if they say, what is Maurmyers stone punch? Explain. So you can explain the equipment and then mention advantage and disadvantage. If the question is like, what is Maurmyers stone punch physical appearance? Could you explain the structure? Then just explain only the structure, because if you do the structure extremely good, the examiner may have the advantage and disadvantage as a next question, but he may skip it. He knows that, okay, he knows the structure so good, he's explaining the 25 French, he's explaining the sturdiness, he's explaining the metal jaws crushing the stone. If I ask advantage and disadvantage, he's going to answer. So there is no point in that. So he may go to a different technique. Okay, how will you do percutaneous removal of the bladder stone? So the examiner's aim is not to ask a question for which you know the answer. That is not the aim. The examiner's aim is to take you into as much depth as possible to see how depth and how understanding is your knowledge. If there is a doubt about understanding, they will stay there and ask another sub question to make sure that the examiner is confident that you understood. But if the examiner is confident that you understood, they will just move on. And that's why in a patient with bladder tumor, I've seen some candidates have reached radical cystectomy with ileal conduit reconstruction and follow-up, and then stricture at the ureteroileal anastomosis, and how will you do it endoscopically, revision of the ileal conduit. The examiner will be very happy to progress, and you should also really progress with the examiner, because as you go to the higher level questions, the mark will be better.
Yeah.
Good. Very good. That's well done. We will stop this scenario as of now. Is it okay?
Yeah, that's fine.
Good.